Go ahead.
We have a number of questions from the audience, so let's start. I have a couple of questions to Carl. I have to apologize because I haven't seen one manifestation related to the COVID-19. All I've seen a lady who developed just the same day or the after being vaccinated the second time, an optic neuritis. So it could be related or not, I don't know, but it's a question. But I haven't seen one case because we were isolated from those patients and we went on working regularly. So the two questions would be how to treat optic neuritis after Pfizer vaccine. This is quite similar to my remark. And does a newly diagnosed phoria without diplopia needs to be checked for committance, and that's for Andy.
Well, I'll take the first question if that's okay about the COVID. So of course, the one of the questions is, well, we know that any vaccine can rarely result in optic neuritis, or at least there's an association time-wise. I don't think there's really great evidence base that tells us how to treat it. We think, of course, optic neuritis is inflammatory, related to the immune system being cranked up, and I would offer steroids in that case. I don't think there's evidence for that, especially with any of the COVID vaccines, because it's all too new. And, you know, we see optic neuritis all the time as neuro-ophthalmologists. I can't tell you I'm seeing any higher incidence or rate of optic neuritis than I've seen in years before the pandemic. So I would probably treat it as I would treat any optic neuritis, but with the thought that it's probably not MS and demyelinating, probably, and treat the optic neuritis in that fashion. But curious certainly if other speakers have other opinions.
Andy, should I repeat your question?
Sure.
Does a newly diagnosed phoria without diplopia needs to be checked for committance? Is it mandatory? And we have another one for you. What is the ideal management for oculomotor cranial nerve schwannoma in a 10-year-old female patient?
So aphoria is a pre-existing tendency for the eye to drift, and that can become symptomatic intermittently. And so those intermittent phorias can become intermittent tropias. And then when it becomes a manifest deviation, it becomes a full-blown manifest tropia. A lot of people, including me, have phorias. So phoria is kept in check by fusion. And so the committance issue really isn't as important as making sure that there's no ductional deficit and that it's not tropic or intermittently tropic. So phoria, probably a lot of people have that. I don't think that's that big a deal. The other question, how do you manage an schwannoma of the third nerve? Is that right, Shlomo?
Correct.
So schwannomas are benign, as you know, and they can present as third nerve palsies. They're often partial palsies, and they're slow growing, so the patient's third doesn't really go away, and usually it progresses. However, it's super slow, and if you take it out, you'll get a third nerve palsy, which is the thing they already have. So normally we just observe those for clinically and radiographically. We have given stereotactic radiotherapy to some of those lesions to try and make them smaller. We have had some patients with big lesions with exophytic components. Those can be debulked. In a kid, probably we just follow the patient clinically and radiographically, and you might consider radiation therapy and debulking of the exophytic component if there's mass effect, but only for big lesions.
Okay, Carl, another question for you. If a patient developed CNP after the first dose of vaccine, what would be your treatment strategy as well as your recommendation for the second dose?
So if there's a cranial, I presume they mean an oculomotor cranial palsy 3, 4, 6 after a vaccine. I think my treatment would simply be to observe. I don't think I would necessarily treat them with anything. I've seen some number of patients over years with that story. Again, depending on their age, is it the typical microvascular age range? Then who knows? Is it really the vaccine or not? But of course, you're not going to be able to convince the patient otherwise. But I would observe them in that scenario, I think. Honestly, in terms of imaging, would I image them? I probably would image them just to be on the safe side, given that scenario, to make sure there's no other areas of inflammation or CNS inflammation. But I probably would observe and expect it to improve spontaneously.
Well, we have another two for you. How could you differentiate between the MOG antibody-mediated optic neuritis and the COVID-related optic neuritis?
Yeah.
And have there been any neuroophthalmological pathologies after the COVID vaccine?
So the first question, differentiating between COVID-related optic neuritis and MOG. I mean, one of the questions is, why do you have the MOG antibodies? So in the case report I showed, one possibility is that the COVID infection caused the MOG, the MOG antibodies themselves. So I mean, we don't really know why people have MOG antibodies to begin with, but there are reports of MOG antibodies being produced by an infection. And so it's sort of a chicken or the egg kind of a thing, I think. So I think the bottom line is, I'm not sure there is a way to differentiate. And again, remember when we talk about manifestations, these are really just associations as yet. It's not, I don't think there's really good proof that it's necessarily directly related to the COVID, the infection itself. So I'm not sure that there is a way to differentiate those two things at this point in time. Maybe with future patients and data, we'll know more. The other question had to do, can you repeat the other question?
Any neuro-ophthalmological pathologies after COVID vaccine?
So I'm not sure, after the vaccine. So I'm assuming when you use the term pathology, you mean findings as opposed to actually like pathologic specimens. Yeah.
Associations, perhaps.
After the vaccine, I can tell you that there have been a number of case reports of occurrences after the vaccine. I've had a number of patients. Of course, in the US, we have 270 million people who've been vaccinated recently. And guess what? Some of those people are going to get neuro-ophthalmologic problems just like they would if they didn't get vaccinated. So whenever someone has something happen after a vaccine, they will ask me, I had the vaccine a week ago, a month ago, a year ago, or maybe not a year, 8 months ago. Could it be related to the vaccine? And I say, anything's possible. We know that vaccines crank up your immune system. But again, without having really big data about how commonly we see these manifestations after the vaccine, we can't compare it to what do we normally see? What was it like before the pandemic? Because again, I practice exclusively neuroophthalmology all day, every day. I see patients with all of these findings. I don't think I'm seeing them any more frequently. And so I don't think we know the answer to is the vaccine causative. We know that just historically, any vaccine, and that's what I tell patients, any vaccine is designed to crank up your immune system, and you could potentially have a neuro-ophthalmologic manifestation related.
Andy, a question for you. How do you examine a patient with unilateral sudden midriasis?
When you have an acute dilated pupil madriasis, of course, you have to make sure that's not a third nerve palsy first. That's making sure the lid and the motility are full. But if it's clearly just the pupil, then the normal things are something wrong with your iris, something wrong with the junction because it's pharmacologically blocked, or an acute adhestonic pupil. So those are kind of the three things. So the first thing is making sure it's not a third. If it's clearly just an isolated madriasis, then you have to decide whether it's the muscle, the junction, that slit lamp, make sure there's no uveitis, usual things. The most common things that I see from a pharmacologic dilation are scopolamine patches and inadvertent exposure to either plants or drops of some kind. And you can test for that if it's a pharmacologically blocked with parasympathetic with pilocarpine 1%. In the adistonic pupil, we used 1/10% palo to see if there's denervation supersensitivity, but because that takes a little bit of time in the acute setting, that might not work. And we're going to look for the usual things in adistonic pupil: the light near dissociation, the vermiform movements, the sector paresis, and most of the time it doesn't matter, because if it's pharmacologically dilated, it'll just go away. If it's adistonic pupil, it will declare itself over time to be adistonic pupil. And if it's something in your iris, you can see that on the slit lamp.
Shlomo, if I could just add a comment about the dilated pupil. We have a paper submitted about, I'm not sure about worldwide, but in the US, there's a new drug, and it's called Qbrexza glycopyrium, which is for hyperhidrosis, for sweating. It's an ointment you rub on your armpits, basically, and that can cause madriasis. So we've seen several patients, and we have some number of cases that are being reported of unilateral or bilateral madriasis following this new hyperhidrosis medication ointment that's available, at least in the United States.
Now, another question for you. Would you do a second vaccination if the first one caused neurological symptoms like whatever?
Yeah. So if you had let's say you had double vision, a week after the first vaccination, and looked like a third nerve palsy, or more likely a sixth nerve palsy, would you have the second dose? Of course, the first thing to say is there's no evidence base to provide an answer for that. In other words, I don't know the answer. I don't know what might happen. I think I tell most patients that I certainly can't guarantee you won't have the same thing happen if you have the second dose of the vaccine. And I think I would tell the patient, listen, you're going to have to make your own decision, because I don't have a way to advise you using what we try to use, which is evidence-based medicine. I think most patients probably would choose not to. I've had that come up twice so far, not a lot, not a large number, and they both have decided not to have the second dose. Now, they've asked me, what about a second dose of one of the other vaccines, not the same vaccine? I said, well, we really don't know anything about that. So I can't give them you have to do this or you don't have to do this. I tell them it's going to be up to you. And the good news is, if it went away the first time, probably go away the second time.
That's a nice one. Andy, a very quick question. What would be a nice pearl for you of differentiating a new onset of diplopia in a myasthenic patient?
Myasthenia is characterized by variability and fatigue, so we'd like to get that kind of history out of them if we can. I like to ask them if it's worse at the end of the day or better in the morning when they first wake up, and we tell them to take selfies of whatever they see. So if it's ptosis or diplopia, we selfie, morning, lunch, and evening, and see if we can demonstrate that variability and fatigue. And of course, you have to have no P's, no pain, no pupil involvement, no proptosis, no perception loss, no paresthesia, no Lee's P's allowed. If you have any of those, it's not myasthenia. And often the ptosis can be tested with the rest test or the ICE test. If it's diplopia, we don't really have a good ICE or rest test equivalent, but we do try it on them to see if it will get better. Sometimes it's difficult to tell. I always say it could always be the nerve, the muscle, or the junction. And so you need to be thinking about myasthenia and any unexplained pattern of ophthalmoplegia, as long as no P's are present.
Do you do tensilon test?
I don't do the tensilon anymore. The ICE test and the rest test kind of took over everything for us.
Thank you, Andy. We'll close the Q&A session. And we will now.
Can I just step in as the second moderator in transition here to explain to our audience that Gordon Plant was unable to be here for the many questions that you asked about his talk. If you have no objection, Shlomo, let me take one of the questions that I think many of the audience members were sensitive to, and that's the difference between the aura of epilepsy, occipital epilepsy, and the aura of migraine. And at least for me, I think we should say that you sometimes cannot tell. So you have to be a little bit on guard that you can't make that distinction. And Gordon Plant pointed to an article that he had written in which a lesion of the occipital lobe had produced migraine-like aura. So that's the first point. However, you can use, I think, three things that are helpful in distinguishing migraine. One is the duration, and Gordon mentioned this, the duration of the aura, namely lasting up to 20 to 30 minutes. That is unusual in epileptic aura. It's not out of the question, but it's unusual. The second is color. If you hear that the patient has a colored scintillation, a colored hallucination, that will point you in the direction of epilepsy. It does occur in migraine, but it's extremely rare. And the third thing is the traveling wave that he described as the traveling wave of Dr. Liao from Brazil. That is much more typical of migraine than it is of epilepsy. The problem there is that somehow people who have lesions that are in the occipital lobe can sometimes evoke a migraine aura. So you're still not off the hook. And where we usually make the important distinction is if you've had more than one episode on the same side, you have to be at least thinking of the idea that this could be a structural abnormality rather than migraine. If you hear that it went from one side to the other side, then that is a big sign of relief. And you don't have to worry so much about this being a lesion. Remember, these are tumors and or malformations, and so you have to be thinking.